Welcome. Thank you for joining. My name is Dr. Ben Miller, and I am pleased to welcome you to today's Congressional Briefing addressing maternal suicide, co-hosted with our partners at the American Foundation for Suicide Prevention. I'm a proud member of the Board of Directors of the Policy Center for Maternal Mental Health, where our mission is to close gaps in maternal mental health, which includes reducing maternal suicide, a leading cause of maternal mortality. Before we get started today, just a few quick housekeeping details. First, I anticipate there's going to be several questions that you all have about our topic. We welcome those. Rest assured, we're going to have ample time budgeted in to get to those. Please use the Q&A feature in Zoom to ask questions of our panelists, and I'll integrate them within our session as quickly as I can. If you're a member of congressional staff, please add an asterisk in front of your name so we can be sure to prioritize your questions. Next slide, please. As many of you know, today is World Suicide Prevention Awareness Day. It's a day when we come together to reflect on the lives we've lost and the work that's still ahead of us. There's major work to do. Between 2011 and 2022, more than 500,000 lives, 539,810 to be exact, were lost to suicide, with 2022 marking the highest number of deaths ever recorded. During this time, we've adjusted the adjusted suicide rate rose about 16%. Today's topic is a tough one to talk about, and I want to acknowledge this up front that if anyone is watching finds this themselves or someone they know in need of help, there's a National Mental Health and Suicide Prevention Hotline number 988 that's on your screen here in front of you that you can call that can immediately connect you to someone who is able to talk you through what's going on with you. Next slide, please. So as I mentioned, today we are going to talk about maternal health and suicide in this population. Data show us that maternal depression affects as many as 20% of women in the US during pregnancy and the postpartum period. Anxiety and depression impacts nearly a quarter of pregnant or postpartum women. The perinatal population is also impacted by maternal mental health conditions like PTSD, OCD, and others, or even the rare but dangerous condition called postpartum psychosis, which is another risk factor for suicide, which we'll hear about today. We also know that women who face increased stressors at home are at higher risk, like those who live in poverty, are of young age, or face interpersonal relationship violence. But beyond the data, we have stories. Some of you may have experienced this issue personally or seen a loved one experiencing it. Maybe you've been on the receiving end of a phone call when a friend calls to share their struggles. Maybe you've sat across from someone telling you about the worst time that they've had. Issues of mental health affect us all, and it's on us, each of us, to find a way to address the problems when they arise. Today, you're going to hear a lot about the problems, the prevalence of the issue, and I ask that you not see the data that we'll share today as only numbers. It's too easy to become desensitized to the magnitude of this problem. Each data point is a life. A loved one, a friend who we've lost, impacting entire families and communities. It's in response to these lives that we've lost that we must be bold, take action, and rise to meet this moment. You're going to hear solutions today as well, exciting ways that we can better integrate suicide prevention, maternal mental health treatment, and supports into healthcare in our communities. And let's not see these as nice to have, but as imperative to helping an entire group of people who deserve better than what we've been doing. Let's begin to do things like widely deploy systems to screen and identify mental illness and other risk factors, but also be ready to take action when a woman explains that she's experiencing thoughts of suicide. Next slide, please. Before we begin today's briefing, we would like to take a moment of silence to honor those who have lost their lives to maternal suicide. You can view their names and learn more about these mothers who have died by suicide on the website that you'll see here in the chat. And we just take a moment to reflect on that for a second. Thank you. We are honored today to have a couple of our members of Congress kind of share their thoughts with us. Congressman Miller Meeks, who represents Iowa's 1st District, unfortunately cannot join us today. She's a doctor, a mother, esteemed member of the House Committee on Energy and Commerce and Committee on Health, and a co-chair of the Bipartisan House Suicide Prevention Task Force. We thank her so much for her support and what she's done in terms of leadership. It's now my honor to introduce a recorded video by Congressman Don Beyer, who is serving in his 4th term as the U.S. Representative from Virginia's 8th District and a true champion for suicide prevention in the U.S. He's been instrumental in the passage of things like 988, which I mentioned already, the Suicide and Crisis Lifeline, as well as championing other key pieces of legislation like the Campaign to Prevent Suicide Act and the Suicide Prevention Lifeline Improvement Act. Congressman Beyer, really want to thank you for your leadership, and we'll allow the video to play here.
Hello, my name is Don Beyer, and I'm a member of Congress from Northern Virginia. But more relevant for our discussion today, I co-founded with my good Republican friend John Katko the Task Force on Suicide Prevention in Congress about 10 years ago. And right now I'm honored to serve as the co-chair of the Congressional Mental Health Caucus. And today we're talking about something that's very important to us, which is the suicide challenges of maternal mental health. You know, the young mothers who get into the postpartum depression and end up losing their lives at a time that's probably the most important time in their life for them to be dedicated to the other, of service to that newborn child. You know, it's really important that we talk about suicide in unfettered ways. When I was a kid, we would never talk about it. Almost to bring up suicide was this great shame, this great stigma. And if someone in your family had died by suicide, we never talked about it. We just pretended it didn't exist. And yet we've learned through the many years that it's by talking about it, and to talk about the need for therapy, about intervention, about the suicide lifeline, about mental health training at every level of our age, you know, high school and college and old folks, that it changes it. In fact, one of the most important things we're trying to do on Capitol Hill right now is to get the Campaign for Suicide Prevention, which is mostly about education, how we talk about it, how we intervene with our friends and our neighbors and our loved ones. That makes all the difference. But today you're specifically here to talk about maternal mental health, which is so critically important, because as we look at a nation where we have roughly 50,000 Americans died by suicide last year, it's creeping up year by year by year. And one of the most sad places, other than youth suicide, is maternal suicide. You know, the change is trickling down to Congress in different ways. We've had lots of conversations about maternal death, which is much higher in the United States than in many countries around the world, much higher than it should be and could be, and also about suicide and realizing the links that they can play. Usually don't get too personal, but my beloved mother-in-law, gone 20 years now, tried to die by suicide after the birth of her 3rd child. Spent a year in a hospital away from the 3 children she'd already had, and was something the family didn't talk about much. The good news was she had a loving family that came around her. She went on to have 3 more wonderful children, including my wife. So we know there are good outcomes out of this, but it's your work today in this conference that's going to make all the difference as we address the real risks that are out there. I'm deeply involved in our artificial intelligence, primarily because we want to use AI to discern, to try to predict who's going to be most at risk and be there for them at that time. You know, we got the 988 lifeline now, almost 2 plus years, July 16th, 2022. And since then, the lifeline calls have almost doubled. That's a wonderful thing, because we find that when we intervene, our opportunity to reduce the risk to actually prevent an unnecessary death skyrockets. Thank you for being part of it. This is something we all need to come together to work on, and I'm very pleased that you're taking the leadership role.
We appreciate Congressman Beyer for his comments and his leadership, and thank you for sharing your family story today. Thank you, Congressman Beyer. I want to briefly introduce our panelists and get us started. So I'm going to do something that's quite difficult, is to summarize these amazing experts and all their experience in a very truncated way. So I'm going to quickly run through these. I highly encourage each of you to look them up online. They have amazing bios and are doing some pretty wonderful things. The first of our speakers is Dr. Jill Harkavy-Friedman. Dr. Harkavy-Friedman is the Senior Vice President of Research for the American Foundation for Suicide Prevention. She's got a ton of accomplishments, including published over 100 peer-reviewed articles, established the Montefiore Medical Center, Albert Einstein College of Medicine's Adolescent Depression and Suicide Program, and serving as an associate professor at the Columbia University New York State Psychiatric Institute in the Department of Psychiatry. Dr. Huckabee Friedman will be sharing general U.S. suicide data and insights, as well as getting into a little bit more about the importance of language. Next, we'll have Dr. Catherine Wisner. She's an internationally recognized expert in the treatment of mood disorders during pregnancy and the postpartum period. She's received a substantial amount of money from the National Institutes of Health and has had over 270 peer-reviewed publications and 23 book chapters. Her research has advanced our understanding of the natural history of mood disorders across childbearing, benefit-harm decision-making for pharmacotherapy, and the pharmacokinetics of medications across pregnancy and lactation. She's the former president of the Internal Mars Society, the founder of the Mars Society of North America, and the fellow of the American College of Neuropharmacology, and a distinguished life fellow of the American Psychiatric Association. I look forward to having her comments today. Next, we have Sarah Foster, who's the Associate Director for Policy, Partnerships, and Communication in the Division of Reproductive Health in the National Center for Chronic Disease Prevention and Health Promotion at the Centers for Disease Control and Prevention. She's led efforts to build, support, and advance CDC's efforts in addressing maternal mortality, preterm birth, and the impacts of opioid use disorder on women and infants. Sarah will be talking today a little bit about the latest data from the CDC and ways that we can continue to support addressing quality improvement within maternal health. Then we have Sarah Brummett. Sarah is the director of the Executive Committee of the National Action Alliance for Suicide Prevention. She's an expert in developing and implementing effective strategies for suicide prevention, intervention, and postvention. Sarah was the director of the Colorado Office of Suicide Prevention and oversaw the Colorado Suicide Prevention Commission. Today, Sarah is going to share a little bit about the federal suicide prevention strategy that was released earlier this year. And then finally, we have Cindy Herrick, who's the Senior Editorial Research Manager at the Policy Center for Maternal Mental Health, where she leads the development of issue briefs highlighting research and recommendations on important topics in maternal mental health, including the Maternal Suicide Issue Brief, which we'll be sharing a little bit about today. She's led the Maternal Suicide Program at the Policy Center since 2018 and is an expert in maternal suicide, maternal mental health screening, and peer support. She's a certified peer support specialist and certified perinatal certified in perinatal mental health. She's currently pursuing her PhD in nursing science and healthcare innovation at Arizona State University and is a recipient of the 2023 Hartford Sun Health Predoctoral Scholarship and the ASU Graduate Fellowship Award. So before I turn it over to our panelists, I want to go back to why we're doing this work, why we're talking about this today. And as I mentioned, sometimes it's easy to forget the faces, the experiences, the stories. And so we want to set the tone today by welcoming a mother to tell her story, including her experience with maternal mental health disorders and postpartum suicidal thoughts. Jigna Patel, thank you so much for being here, for sharing your experience to support other mothers in their perinatal journey. Jigna currently serves as the new parents educator at Methodist Hospital, The Woodlands in Texas. She's also a facilitator and coach at Group Peer Support, also known as GPS for Parents, and a volunteer for Postpartum Support International. Jigna, thank you again, and we'll look forward to hearing a little bit more about your story.
I just need to go off mute.
Sorry about that. Thank you so much for having me. I was so excited to just jump into it. I'm very happy to be here. Hi, everyone. My name is Jigna. I'm honored to be here representing mothers with lived experience of a postpartum mental health disorder and suicide. I had postpartum depression, anxiety, and psychosis after the traumatic birth of my daughter 10 years ago. My journey started when my husband and I tried to get pregnant for over a year and couldn't. And shortly after that, I was diagnosed with polycystic ovarian syndrome, PCOS. It's a hormonal condition that affects the ovaries and other parts of a woman in a childbearing age. PCOS was the reason I learned I could not get pregnant naturally. I had to go through fertility treatments to get pregnant, and as anyone who has gone through infertility knows how stressful of a time that can be. After we learned we were pregnant, we were very relieved and excited to start the next chapter. My pregnancy was healthy, but I was very anxious and fearful of a miscarriage. Then the birth of my daughter caught me off guard. It was an unscheduled emergency C-section. My daughter's cord was wrapped around her neck and her heart rate had dropped really fast before they performed an emergency C-section. I felt all the tugging and pulling during the actual surgery because the anesthesia had not fully kicked in. I came out of that surgery that very day mentally disturbed and confused. I developed all of my postpartum mental health disorders right away after that C-section. I had so many scary and dark thoughts that I was afraid to tell my family or my doctors. I had terrifying thoughts of harming myself and my baby. Shortly after giving birth, I was driving one day by myself, and I had vivid images of my car running off the freeway. I had to call my sister and stay on the phone with her so I could stay connected to reality. I had delusions of hitting my 1-month-old baby's head against my bedpost at nights while I was doing nightly feedings. I was nervous to tell any of these stories to my husband or my doctors. I was afraid of being called crazy or being separated from my child. I had other similar breaks in reality, and I just learned in 2022 this was postpartum psychosis, a serious medical condition that requires emergency care and which I had never heard of at that time, and nobody else had mentioned it either. All of this and more led me to have more suicidal thoughts and ideations right after that birth, and I lived with it for months without any help. Now that I know more, I wish that my OB or GP could have seen the signs of anxiety while I was pregnant and known I was at risk. And they could have provided me with a screening right after my birth as well, which was very traumatic and was also another risk factor. But it was at my daughter's 2-month pediatrician visit that I was finally screened by her doctor and not my own. The pediatrician asked me a few questions and instantly recommended a therapist. I ended up going through 3 different therapists, and none of them had knowledge of maternal mental health conditions. They too missed many signs that are different from mothers experiencing postpartum depression or anxiety, let alone psychosis or suicidality. And it's always different from moms and regular depression patients. Over time, a combination of resources and support have helped me with my recovery. This included medication. It was the first most needed step, which I was against, but eventually got on. And it was the beginning of my healing. Sleep is another form of medication. And at the time, I did not give it any importance. And I learned much later that I needed it and I needed therapy to get better sleep. Self-care. And I also went through different types of therapy and different therapists until I found somebody who had a little bit of experience with maternal mental health. And finally, another thing that really helped me was acceptance of allowing my family to care for my baby so that I could care for my own health. I was sick and I was ill, and it was a real thing that was happening to me. And once my anxiety was in control and I got sleep, I was able to think rationally. After much healing and confiding in my inner circle, I learned it was okay for others to help me with my baby. Moms are never meant to do this alone, yet society, your own culture, your own background pushes that theory. I also started to educate myself about maternal mental health through books, podcasts, and webinars similar to this one. Thank goodness that my child's pediatrician knew something was wrong, but for many years, I wondered why my OB or even the hospital delivery team after my birth never mentioned anything about postpartum depression. As a person of color, I also had the cultural stigma and shame added on my list of risk factors, yet none of my providers mentioned anything about postpartum depression, anxiety, or even psychosis. Through organizations like the Policy Center for Maternal Mental Health, we know this is due to many factors, including that lack of adequate knowledge or training that OBs have on perinatal mental health disorders, lack of monitoring or the implementation of clinical practice guidelines, and the lack of payment to the OBs for this particular work. I wish that my doctors would have screened me a few different times in the first few months after birth. And I also wish there was a perinatal trained workers in all OB and pediatrician offices to evaluate every new mom thoroughly after her birth. If I had gotten help at the right time, my postpartum experience would have been much different. Today, I am a mom of 3 amazing girls, and for my second pregnancy, which was a surprise twin pregnancy and brought new challenges, I created a multi-layered postpartum birth plan. This plan cut my depression in half the second time around and also gave me a sense of healthy control of my situation early on rather than much later. I'm also a perinatal mental health advocate and in training to get my perinatal mental health certification from Postpartum Support International, who I volunteered for the last 3 years. I've worked with over 100 moms as a peer mentor and a support group leader. And the main theme that I hear all of them share is that they're scared to talk about their thoughts, what they're experiencing, and even more scared to share about any suicidal thoughts they have. And I give them my story, I give them hope, and I let them know that it's only going to start with them speaking up and asking and deserving help, that they're going to be okay. Many new moms don't have anyone in their corner, but I'm grateful for my husband, family, and friends for being my first advocates and pushing me to get the support I needed and deserved. Thank you.
Thank you so much, Jigna, for your openness and willingness to share. It's not easy. And your story likely resonates with countless out there. Your challenge to us all to recognize the signs and the symptoms and then to do something about it is so needed, especially at this moment. We must increase the knowledge base, and I think you said this beautifully, while we simultaneously change the policy and payment mechanisms to really encourage more OB pediatric settings to do more for mental health. You give us all hope. So thank you for your comments today, and thank you for joining us. You're the foundation for us to do more, to do better.
Thank you so much.
I'm now going to turn it over to Dr. Harkavy-Friedman to kick us off with our panel presentation.
Hi, everyone. I'm Jill Harkavy-Friedman. I'm the Senior Vice President of Research at American Foundation for Suicide Prevention, as Dr. Miller so kindly introduced me. And thank you, Jigna, because you're the reason, and the countless women like you, that we are working to bring this to light, to have these conversations, and to save lives. So you, like Dr. Miller said, you bring us so much hope. Next slide, please. So one of the important things is that what you're doing here today, Jigna, is talking about your feelings and about suicide. And the conversation around suicide has changed. And I'm just going to review some terminology that we prefer and terminology that we're changing. So you may be used to saying that somebody committed suicide. And this is a very important change that's happened both for survivors and for people who are struggling with suicidal thoughts. Suicide is the result of a health condition. And just like we might say somebody died of a heart attack or died from complications of diabetes, we say somebody died by suicide. It's also okay to say they ended his or her life or killed him or herself, but the preferred, because of the health implications, the preferred way to say it is died by suicide. So I invite you to try that on. If you say committed suicide, don't worry about it. You have next time to change your conversation. We also don't rate suicide attempts. We don't say a failed or successful attempt, because that would mean that a failed attempt meant the person lived, and a successful attempt meant that they died. And that's just counterintuitive to everything that we work for. So we just call it a suicide attempt. And if somebody dies, then we call it a fatal suicide attempt. So I invite you to try these terms on. Next slide. I also want to talk about the terminology around maternal mental health. Other words you might hear for this are reproductive mental health, perinatal mental health, perinatal depressive disorder, and postpartum maternal health. Next slide, please. Don't worry about reading everything on this slide. I don't want you to panic, but the point is that the words that we use matter. Imagine that we said to Jigna, oh, mental health conditions don't cause pregnancy-related deaths. That would be a complete discounting of her. Imagine if we said that if I don't understand why you're anxious about birth, but once you hold that bundle of joy, you'll be fine. Because for a person who's struggling with their mental health around the time of the birth of their child, it's hard enough to be struggling, let alone to have people misunderstand. And I think what happened in Jigna's case is not really saying, hey, you have a mental health condition that can be treated and we can help you. So instead of saying, you know, maternal health is doesn't cause suicide, you can say, I wish you were right, but mental health conditions are the leading cause of pregnancy-related deaths. Pregnancy and having a baby can be hard. And in fact, 20% of individuals who will experience a mental health condition during this time. And acknowledging whatever you hear from a mother about what she's experiencing, if she's able to talk about it, that will help what we've learned, that will help prevent suicide and also get her to help sooner. Next slide, please. I want to share a model of how we think about how suicide works, and then I'll add some factors that relate to suicide in the perinatal period. So we all, more than half of us know somebody who died by suicide. And often when we think about suicide, we think about the events and the stressors that occurred to them and think that's the cause of suicide. So you might say bullying causes suicide, or divorce caused suicide, or financial stress caused suicide. But if you take any of those events, which are extremely stressful, for most people, they will make it through without even thinking about suicide, let alone taking their life. So there isn't this direct connection between stress and suicide. Next slide, please. However, there are in the background these biological, psychological, and social and environmental factors, and I'm going to talk a little bit more about that in a second, that are dynamic. They're always happening. Think about it, like mental health. 90% of people who die by suicide have a diagnosable mental health condition, even though they may not know that they have it. Well, you don't have it all the time. Sometimes you're feeling better, sometimes you're feeling worse, sometimes you're getting treatment. Think about a chronic health condition, same thing. These are dynamic factors that influence each other. But when they are present, and I'm going to talk more about this, could you go to the next slide? When they are present, and there are these many factors: mental health conditions, pain, chronic health conditions, victimization, abuse, neglect, family history, having had a head trauma. There are all these factors that contribute to the risk for suicide. And when there is a current event or stressor, a person's risk may increase. Now, any one of these factors alone will not cause suicide. It's a confluence or convergence of several factors in the context of life stressors or major life events. Could you just push the button again? Because this is my, oh, sorry, go back. I had a dynamic thing going there, but no, you can go back to that one, perfect. The thing is, you can't die by suicide unless you have access to lethal means. So these factors may be happening, there's a stressor, and if someone has access to lethal means, they could die by suicide. So I want to refute the idea that suicide comes out of the blue. And what we're trying to do is turn hindsight into foresight, to think about maternal mental health as one of those factors that could be happening that could contribute to suicide. I want to share some numbers Dr. Miller shared already. Next slide, before I go into risk factors. Over 49,000 people died by suicide in 2022, representing about 14%, 14 per 100,000, 14.1 people who died by suicide. 13.2 million people seriously thought about suicide when asked about it. 3.8 million people have made a plan for suicide, and 1.6 million people have made a suicide attempt. So if we think about it, suicidal ideation and behavior is quite prevalent in the general population. But I also want you to keep in mind that most people who think about it do not make a suicide attempt, and most people who make a suicide attempt will not go on to die by suicide. So about 10% will go on to die by suicide. So we have to stop acting like thinking about suicide is an emergency. And we want to get people to think of it more as a crisis moment that you can get help. And that's where 988 comes in. So I encourage you to spread the word that 988 is available for people in those crisis moments to help de-escalate the problem and also help bring support and help and provide options for where you could go to get help. Because like Jigna said, getting help made all the difference. Next slide. Thank you. So this is the suicide rate across from 2000 to 2022. The rate recently has been, I would say, leveling off. There are slight changes, but it's far too high. And we think of any death by suicide as a tremendous loss. And research shows that actually one death on average affects at least 135 people. So if you think it's just a family matter, it's much bigger than that. We need to be talking about it and supporting each other. Next slide, please. It cuts across all races, and I want to highlight here that suicide is most frequent in the Native American, Alaska Native, Indigenous American population, and then among white people, but it is present in all groups. And when we're talking about maternal mental health, we have to keep in mind that people of color, particularly Black women, experience physical health problems that jeopardize their physical health in addition to maternal mental health. And so we have to pay attention to every woman who is giving birth and checking her in with her about her mental and physical health. Next slide, please. And I just want to call to attention how most people die. More than half of people who die by suicide use a firearm, and this is more, this rate is increasing for women. So just keep in mind that if you have lethal means in your home, please try to remove it or secure it so that if a person is in distress, we know that if they don't have access to lethal means, even if they find another method, which is they usually don't, but even if they do, they're less likely to die from it because it will be non-lethal, and most people who make attempts do go on to engage in life. And so saving people in that moment of crisis is critical. Next slide, please. I'm going to talk a little bit about some of the risk factors for perinatal suicidal ideation and behavior, otherwise known as SIB. First of all, there are environmental factors, social and gender inequality, social and racial discrimination that affects access to care, belonging to certain ethnic and religious minority groups who are marginalized and do not get the same medical attention and mental health attention, crowded or inadequate housing, living in rural areas, exposure to disaster, conflict, or war. These are environmental factors that can increase the rate of suicide. There are also gestational factors about the birth itself, including, and that have to be considered. Listen to Jigna's story. She had a traumatic birth. That means like from that second on and during that crisis moment, her mental health is of critical importance. Next slide, please. There are clinical factors such as previous psychiatric disorders, history of suicidal ideation or attempts, and having more than one mental health condition or psychiatric disorder. But keep in mind that somebody could have a postpartum mental health condition and be at risk for suicide, having never had that before. In fact, 60% of people overall who die by suicide die on their first attempt. So while that's important to know about someone, we should not assume that if they haven't had that, they're not at risk. Next slide, please. I just want to note, and I think as Jigna said, several of these were present for her. Anxiety, depression, psychosis, and also substance use are the most prevalent disorders in postpartum mental health distress. And I think you're going to hear more from about that soon. So I want to say a word about screening. Next slide, please, and intervention. First of all, I had a slide that said that all the mental health and perinatal and OBGYN organizations believe that there should be screening for mental health and suicide during the perinatal period for women. After screening, there are actually very effective treatments to prevent suicide. And so in addition to medication, which as Jigna said, was primary for her being able to access any other supports, the first step is crisis care and support, like calling 988. There are brief interventions for people at risk, like safety planning, crisis response planning. Then there are therapies, and what we've learned is that you have to address both the underlying mental health condition and the suicidal ideation and behavior directly. So cognitive behavior therapy for suicide prevention, dialectical behavior therapy, and collaborative assessment and management of suicidality are three treatments that have lots of evidence that they work. Sometimes emergency respite care, which goes along with the idea that the mother may need to just have some time to sleep and to recover. Partial hospitalization programs and inpatient hospitalization programs that include suicide-specific interventions. Now, we do this in this order of increasing intervention. So just start with crisis care. Most people will not need to be hospitalized or partial hospitalization. Either crisis care or a brief intervention or the outpatient therapies plus medication will be effective. So I'm going to share some resources, but they're just going to be flashed on the screen. Next slide, please. And thank you very much.
Thank you, Dr. Harkavy-Friedman. I really appreciate your call to action here. There's so many nuggets of wisdom in what you just said, including the importance of being clear with our language, both how we refer to things like suicide, as well as how we talk to people who are going through their own mental health journey. I really appreciate that. I also very much liked your call out about the risk factors and differentiating those from the protective factors and how we need to have a focus on both to have a successful strategy there. And then finally, that little nugget at the end on one size isn't going to fit all, and really being both culturally sensitive and appropriate and looking at the differences between all of our communities is one of the best ways forward in addressing these substantial issues. So thank you for your leadership and thank you for joining us today.
Well, thank you so much.
Thank you. Next, we're going to turn to Dr. Catherine Wisner. Dr. Wisner.
Thank you so much. And it's a real pleasure to be here, to be able to speak with you this afternoon. We've got Sarah's slides up, though. I think mine were before hers, or there we go. Okay, thank you. All right, I'm going to talk about the identification and treatment of perinatal mood disorders. Next slide, please. The objectives of my talk are to describe the perinatal disorders, talk about reproductive psychiatry as a special area of clinical care and research, review briefly risk factors, since we've heard much about that, and talk about suicidality in the perinatal population, treatment options, and end on the note that Jill highlighted, which is suicide is preventable. I'll also share some resources. Next slide. Perinatal mental illness contributes to pregnancy complications so that all of the illnesses, conditions, problems that we think about in pregnancy, miscarriage, hypertension, preeclampsia, cesarean section, NICU admission, all of these complications occur at a higher rate, often about 1.5 times as high in women who have mental illness compared to those who do not. We also worry about early social support for an infant. So if a caregiver like this mom in the picture is overwhelmed with her own emotional regulation, her ability to help that infant regulate the agitation, the crying, and move to, say, an awake alert or a sleep state is compromised as well. And long-term, this can lead to poor attachment as well as developmental difficulties and behavioral problems. So this observation about the importance of mental illness and pregnancy outcomes led our OBGYN colleagues to make this statement about perinatal mood and anxiety disorders being associated with increased risks of maternal morbidity illness, which increases the risk for mortality, and that this is a significant patient safety issue. Next slide. So why is this postpartum period so difficult? Well, certainly pregnancy itself as a biological, psychological, and social challenge at adult developmental phase is stressful unto itself. But you get to delivery, and what you're seeing in these charts is the increase in the estrogen and the progesterones across pregnancy that go to very, very high levels, but within 24 hours of birth, plummet to very low levels. And those hormones have receptors in the brain as well. So you've got this assault that occurs with delivery that leads to pain, stress, biological 24-hour rhythm disruption, changes in sleep cycles, and again, potentially obstetrical complications, and for some women, overt trauma. So we really underestimate the stress that labor, delivery, and birth create for the mothers in our population. Next slide, please. So I did a study about a decade ago where I screened 10,000 mothers who delivered at an urban obstetrical hospital. And I screened them at 4 to 6 weeks after birth with a measure to assess depression. 1 out of every 7 women screened at 4 to 6 weeks post-birth, 14%, 1 out of 7 women screened positive for depression. And we know that if we continue to screen in the first year, the rates are higher, 20 to 25%. So this is an incredibly common situation for our mothers. I then did psychiatric interviews on home visits or telephone assessments of the women who screened positive. And when I asked them, when did this illness begin? About a quarter of them said, it started way before pregnancy. This is a chronic depression. So the opportunity to intervene was missed until 4 to 6 weeks postpartum. About a third of women said it began in the 9 months of pregnancy. Again, missed opportunity to intervene. And about 40%, so the majority of women said this started after birth and it was identified at 4 to 6 weeks postpartum. So the majority are in this very brief postpartum window, a burst of cases that we have known for millennia and have done epidemiologic studies for centuries on the influence of the postpartum period on major psychiatric illnesses. Next slide. So when we did our diagnostic assessments of these mothers who screened positive, we found that major depressive disorder, not usually the first episode were we identifying, but often a recurrent pattern of depressive episodes. And the vast majority of those women also had a comorbid anxiety disorder that usually began in childhood. And we know that anxiety disorders kind of the gateway to recurrent major depressive episodes. This has led to the term postpartum or perinatal mood and anxiety disorders to recognize that common comorbidity. The other important finding was that of those women who screened positive for depression, they had bipolar disorder. So not unipolar depression, but a cyclical form of mood disorder. And we know that the postpartum period is the greatest time in a woman's life for the recurrence of that disorder or for the identification of it. We found in our assessments that the majority of these women had not been diagnosed as bipolar because it's somewhat difficult to diagnose. And we had done very structured psychiatric assessments to explore for that. This is a problem nationally in our field, earlier identification of bipolar illness. It also carries the highest risk for suicide among any of our psychiatric illnesses. Next slide. So we've been talking a bit about postpartum psychosis, and it typically is estimated at 1 to 2 per 1,000 births. I believe that's an underestimate and refers to the very rapid onset psychosis with hallucinations, delusions, very bizarre behavior. But there is also a form that looks more like depression in the immediate postpartum period that gets worse across time and leads to sort of progressive psychotic symptoms. And that is something that's a little bit harder to identify, but can be identified through screening. Postpartum psychosis is almost invariably a manifestation of a cyclical mood disorder, either a euphoric manic state or more commonly a mixed state with agitation, depressive symptoms, with hallucinations and delusions and very bizarre behavior. It's important to note that with treatment, the prognosis is very good. And what I think is really important is that if a woman has an episode, preventive treatment after another birth is also very important. I also included on this slide a TED Talk by a person with lived experience, 2 episodes of postpartum psychosis that'll complement the wonderful overview that Jigna gave you of her very sad experience. Next slide, please. So we will see again headlines like this. This is Lindsay Clancy, the woman who was a labor and delivery nurse who was viewed by her friends as she lived and breathed for her children. She killed her 3 children in her basement at 8 months postpartum, slit her wrist, and jumped out a 2nd-story window. She is currently disabled and is either undergoing trial or the trial. I'm not sure what the status is, but she is somebody who is one of the more recent people who unfortunately succumbed to postpartum psychosis and has had devastating consequences. Next slide. So Jill talked about the social determinants, which are critically important, again, in thinking about the background of these mothers who come to pregnancy, who have kind of cumulative disadvantage, or what's termed as weathering, so many building stressors and challenges to their coping skills so that the stressors really outweigh their ability to cope. There's often repeated lifetime trauma. In our population of women with depression, when we asked about physical and sexual abuse, it was 25 to 34%. It was even more intense, up to 50% in our patients with bipolar diagnosis. So this is something that's come to far more attention in our field more recently, the histories of trauma and the need to deal with, to do trauma-informed treatment or overt treatment for PTSD in these populations. There's also limited access to care that we'll hear more about, racism, mistreatment. And again, here we have in our country, no paid parental leave by national policy. Many of these patients have very low wages. They will come in and say, well, I had to go back to work a month postpartum because I could not get diapers if I didn't go back to work. So very challenging situations with limited community supports. And we look at the diagram where you've got in green, what's the contribution of healthcare? And you see this overwhelming economic factors, physical environment, health behaviors. And so our capacity to really impact health depends upon shifting the way we think about healthcare to embrace these other contributors. Next slide, please. In that sample of women who I screened, we also looked at their scores of depression on an item in the screen. And if we screen at a lower level, that is a score of 10, which is what we screened with, about 20% of women endorsed suicidal ideation at some level. We screened at 13, which is the clinical measure that's typically recommended, about 30% screened positive. And that is, they either said, I hardly ever, sort of low level, but still think about suicide, sometimes, and yes, quite often in the red. So thinking about suicide, as we've heard, is not unusual in postpartum women, where our greeting cards tell us what a wonderful time this should be. Next slide, please. Getting back to experiences, I think it's really hard for many people to understand how it is somebody could want to end their life. And what I've learned from patients is it's if you can imagine the most negative time in your life you've ever had, it'd be really anxious, really sad, angry, but having that be persistent and never lift, not having any way to mitigate that awful negative feeling, so that the motivation to try to do things that will reduce that horrible emotional pain, which for many people is worse than physical pain, is very tough to contemplate. So I want to share this poem by one of my patients who gave me this on her birthday. Nothingness. All hope is gone. There's nothing left. The nothingness consumes me, eating away at me until I am broken and shattered, dead, a murdered soul, killed by the nothingness. I still walk and exist, but I don't live anymore. A dead soul walking on earth, killed by the nothingness. I can say that with treatment of her bipolar illness and therapy, she's now a college student. So again, these things are treatable. Next slide, please. So again, I'll say treatments are available, but we must expand access and also education. We've heard Jill talk about psychotherapy skills, managing patients in a way that says, okay, I'm listening to you. I understand why you might want to hurt yourself. Let's view this as a crisis. What are the reasons you might want to hurt yourself? What are the reasons you don't want to hurt yourself? There's this tension between wanting to live and die that is a very good place to start in doing therapy with patients. It's also critically important to treat these underlying illnesses. So we have antidepressants for depression and anxiety disorders. For bipolar disorder, these three medications, lithium, clozapine, and folic acid, have all been shown in large-scale studies to reduce the risk of completed suicide when administered to populations. And that's really rarely known. We need to do much more education in that regard. There are novel interventions. There's a new medication, a neurosteroid for postpartum depression. That's a 14-day administration of nasal esketamine, an FDA-approved medication for depression, light therapy, transcranial magnetic stimulation. And I say that because not everybody responds to first-line treatments, but we have other powerful treatments to offer. I also want to point out how important it is to integrate care, to put the person back together again, so the poor person doesn't go to her obstetrician, her dermatologist, her psychiatrist, her rheumatologist, her kidney doctor, and get all kinds of information, but we form units of collaborative care around patients to deliver care to her as one unit, one person, as opposed to the relatively fragmented ways we do now. Next slide, please. So I wanted to leave you with some resources, and this is one done by one of my colleagues at Children's Hospital that is a lecture on implementing therapy for perinatal patients who have suicidal ideation. That is a really, really nice overview. Next slide. I think that may be. Okay, very good. So thank you very much. I do want to end with remembering my patients, colleagues, and family members who have died by suicide.
Thank you, Dr. Wisner. Such a tour de force of wisdom there. So many nuggets that I think we could take away, including just how we can begin to really look at the evidence and how there are so many different studies out there that show what works. And why aren't we using those more? I really loved your call to action and a very clear call to action on the importance of increasing access, and not just access to traditionally fragmented care, but access to truly team-based integrated care. So important. And your weaving of the stories there was just masterful. So we thank you for that. We're going to go next to Sarah Foster. Sarah, thank you again for letting us do the slide shuffle here. We'll turn it over to you. Hopefully nobody's looking at the slides. We won't give too much away. And take it away.
Thank you. Thank you for the opportunity to join you all today on this important topic. As you've heard, perinatal mood and anxiety disorders are a frequent complication of pregnancy and childbirth and are associated with maternal depression, anxiety, and increased risk of depression and anxiety in children. I'm going to share some information today on CDC's work with MMRCs to address pregnancy-related mental health deaths and our work to improve outcomes for young families. Next slide, please. The CDC has been working to build the public health infrastructure needed to better understand and prevent maternal mortality. Maternal mortality review committees, or MMRCs, provide us with the most complete picture of pregnancy-related deaths. MMRCs bring together information from a wide range of sources, including informant interviews, and provide much more detailed information about these heartbreaking deaths than was available before. We get information on the timing of death, the underlying causes and circumstances of deaths, and the potential preventability. Their work provides data that can drive action, protect the health and well-being of mothers, and improve the lives of women and families. Next slide, please. CDC first got an appropriation in 2019 to support MMRCs, so we have seen a lot of growth in a relatively short time. MMRCs provide detailed information on pregnancy-related deaths. Because of this more in-depth process with a group of diverse experts, MMRCs are able to identify if mental health deaths are pregnancy-related. And that means that a death that was causally linked to the pregnancy during or within 1 year of the pregnancy. Death certificate data alone cannot provide this information. But it was also beginning in just 2018 that implementation of the revised death certificate with the pregnancy checkbox was complete in all 50 states. This also supports newer availability of vital statistics information with a broader look at pregnancy-associated mental health deaths, that is, deaths that are temporarily associated with pregnancy. So there's growing information in just the past few years to help us better understand the landscape of maternal mortality and maternal mental health deaths in particular. Next slide, please. So looking more closely at the most recent data from MMRCs in 38 states from 2020, here are the 11 most frequent underlying causes of pregnancy-related deaths. Mental health conditions were the most frequent cause of pregnancy-related deaths. It's highlighted in the red box at the bottom. This includes deaths determined to be suicide, overdose, and poisoning deaths related to substance use disorder, and other deaths determined by MMRCs to be related to a mental health condition, including substance use disorder. Cardiovascular conditions were next, with about 7% of pregnancy-related deaths due to cardiomyopathy and about 10% due to other cardiovascular conditions. And infection was next in 2020, with COVID-19 accounting for about 11% of pregnancy-related deaths and about 6% of pregnancy-related deaths due to other types of infections. There is variation in the leading cause of underlying death by race and ethnicity, with mental health the most frequent underlying cause for white women, cardiovascular conditions the most frequent underlying cause of pregnancy-related death for Black women, and among Hispanic women, the most frequent underlying cause of pregnancy-related death was infection in 2020, with COVID-19 accounting for almost the entirety of infection-related deaths. Next slide, please. In addition to the underlying cause of death, MMRCs also categorize deaths in several different ways to better understand and prevent them. One of those is by looking at the manner of death. Among pregnancy-related deaths with a suicide manner of death determination, MMRCs determined that 9% were either yes or a probable suicide death. Suicide deaths are included within the mental health conditions underlying cause of death category on the previous slide. Next slide, please. MMRCs also document circumstances surrounding a death, including obesity, discrimination, mental health conditions other than substance use disorder, and SUD. These circumstances are defined as whether the circumstance contributed to the death, and not just whether the circumstance was present or experienced. Next slide, please. Committees determined that mental health conditions other than substance use disorder was a circumstance in 26% of deaths. This is determined when the condition directly compromised an individual's health or healthcare and contributed to her death. So, for example, when a mental health condition like severe depression impacts the ability to manage type 2 diabetes, or when severe anxiety disorder prevents a person from obtaining prenatal care. Next slide, please. MMRCs may determine that substance use disorder is a circumstance that contributed to the death when the disorder directly compromised an individual's health or healthcare. So, for example, acute methamphetamine intoxication made preeclampsia worse, or the individual was more vulnerable to infections because of SUD. Committees determined that substance use disorder was a circumstance in about 25% of pregnancy-related deaths. Next slide, please. In general, MMRCs are also able to look at preventability, and overall from MMRCs, we see about 84% of pregnancy-related deaths were determined to be preventable. MMRCs also provide a much more detailed picture about the timing of pregnancy-related deaths, with about half of pregnancy-related deaths occurring 1 week to 1 year after the end of pregnancy. This is a time when most individuals would have left the hospital, underscoring the importance of community connections and postpartum care and follow-up, particularly since we know that parenthood is a life period with many new challenges and stressors, requiring new or refreshed coping and problem-solving skills to manage stress and maintain resilience. Next slide, please. Importantly, in addition to having a better understanding, we are also seeing the difference the data can make. Over time, we've seen a considerable increase in the number of data-driven recommendations from MMRCs that are implemented in states. On this slide, I have two examples of recommendations that have been implemented. So Utah launched a website where women and clinicians can search for providers specifically trained in maternal mental health screening and treatment. And based on their MMRC recommendation, Louisiana realigned their hospital licensing standards to ensure that levels of maternal care more closely aligned with the national guidelines. So as we're getting a better picture of the drivers of maternal mortality, states are able to use that information or their state to begin to address these drivers. Next slide, please. And so in a little bit more detail, what does that look like? Pieces of CDC's infrastructure are coming together with a handoff between MMRCs and perinatal quality collaboratives, or PQCs, leading to change. So for example, Colorado's MMRC identified 3 contributors to mental health deaths, including stigma in the community and healthcare system, fragmentation of the healthcare system, and the need for more clinician training. The Colorado PQC then led a 3-pronged intervention to address these challenges and improve perinatal care. The first arm, Colorado implemented an AIM bundle by partnering with birthing hospitals statewide to institute universal screening and timely referral for individuals at risk of substance use disorder and perinatal mood and anxiety disorders, screening over 8,400 patients for substance use disorder, depression, and anxiety. The second piece established a perinatal support network within communities. This program assists individuals with SUD, perinatal mood and anxiety disorders, and social needs to navigate the perinatal period. Strategies include financial assistance to access mental health treatment, wraparound support to address social needs like food insecurity and transportation barriers, and increasing access to peer-led social support, as well as perinatal navigation, including home visitation. 160 families have been referred to perinatal navigation services, and 85% have elected to continue with these services once they've started. The third arm has enhanced in-hospital access to pharmacotherapy for pregnant and postpartum people with SUD through training and technical support. These collaborative initiatives aim to minimize barriers to care by integrating inpatient screening, treatment referrals, pharmacotherapy access, and community care supports to mitigate maternal mortality in Colorado. Participating facilities and organizations have found success through proactively building and maintaining seamless referral pathways, including direct provider-to-provider handoffs, and maintaining effective cross-specialty relationships through the formation of multidisciplinary work groups. Next slide, please. And so CDC is committed to supporting MMRCs and PQCs throughout the country to ensure robust data drives action and leads to improved care and outcomes. Perinatal education and training programs have been developed to increase coping skills and problem-solving abilities. Supporting resilience through education can really make a difference. In addition to these critical pieces of public health infrastructure, CDC has also strengthened related activities, including the CDC Hear Her campaign on the urgent maternal warning signs, technical assistance for implementing the CDC Locate tool, which helps states to map and strengthen the state's system of risk-appropriate care, and the Pregnancy Risk Assessment Monitoring System, or PRAMS, that gathers information on women's experiences before, during, and after pregnancy to better understand the landscape of maternal health in the U.S. CDC is committed to protecting health and improving lives for young families throughout our country, and we look forward to continuing to work together. Thanks. Next slide.
Thank you so much, Sarah. I really appreciate your comments here. I mean, there's no better music to my ears than to see how we could give states more actionable information to know what to do around suicide prevention. So thank you for sharing some of the examples from Colorado and elsewhere. And also your guidance on what's worked. I mean, resources to help and just the general role of the CDC is so valuable. So we appreciate your leadership and thank you for joining us. Next, we're going to go to Sarah Brummett. Sarah, we'll turn it to you.
Thank you so much, Ben. So as Ben shared, I am with the National Action Alliance for Suicide Prevention, which is really the nation's public-private partnership, bringing together national leaders from across public and private sectors with the express purpose of advancing high-impact areas of the National Strategy for Suicide Prevention, which is what I am here to share a little bit more about. So on to the next slide. The 2024 National Strategy for Suicide Prevention was released in April of this year, and it really reflects a comprehensive public health approach to preventing suicide, including efforts in prevention, intervention and treatment, postvention, as well as calling for improvements in data evaluation and research to guide efforts across the spectrum. So 25 years ago, Surgeon General Dr. David Satcher issued the groundbreaking call to action to prevent suicide. And this call ultimately led to the nation's first national strategy in 2001, followed later by an update in 2012. Today, I am happy to report that suicide prevention efforts have expanded significantly, ranging from advances in data timeliness, the launch of the 3-digit dialing code 988 that you've already heard about today, to progress in prevention, treatment, and research. Additionally, people across the country are aware that suicide is a pressing public health problem that is preventable, but we know that more work is necessary to match the challenge of rising suicide rates. So this 2024 national strategy incorporates the advances in the field and addresses the associated issues of equity, substance use, and the overdose crisis, and the significance of social media, particularly for young people. The comprehensive whole of society strategy is designed to guide, motivate, and promote a more coordinated and comprehensive approach to preventing suicide in communities across the country. It focuses on the many factors associated with suicide, with the recognition that there is no single solution. And with that, carrying out a comprehensive approach relies upon collaboration across public and private sector organizations, the leadership of people with suicide-centered lived experience, and people representing populations disproportionately affected by suicide and suicide attempts. On the next slide, I just wanted to reflect that the creation of this 2024 national strategy was led by partners across the federal sector with support from the Action Alliance and Suicide Prevention Resource Center. So next slide. In addition to that, on the next slide, in the early stages of developing the strategy, we received, so onto the next slide, please. Thanks. In the early stages of developing the strategy, we received input from across the country. Over 2,000 people provided their feedback and input and expertise, including people with suicide-centered lived experience, tribal members, young people, experts, and partners working across the private sector. Next slide, please. The national strategy is structured with 4 strategic directions. I will not go into all of the 15 objective goals and 86 objectives, but I just wanted to keep it at a high level, reflect the full comprehensive approach. So the 4 strategic directions address gaps in the field and promote a coordinated approach to suicide prevention in communities across the country at the national, tribal, state, local, and territorial levels. So the first strategic direction, focused on community-based suicide prevention, calls for communities to select, implement, and evaluate a range of strategies to address the many factors associated with suicide at the individual, relationship, community, and societal levels. So this strategic direction requires coordination for upstream prevention, lethal means safety for those at risk of suicide, postvention supports after a loss or a crisis, engaging in workplace strategies, as well as evidence-informed communication and messaging goals. The treatment and crisis services strategic direction focuses on the critical importance of implementing a systematic approach to suicide care within health systems and emphasizes the structural role of the health system in preventing suicide rather than the responsibility resting solely in the hands of individual clinical providers. This strategic direction also sets the vision for a complete and coordinated crisis response infrastructure that includes not only a 24/7 nationally available crisis line, but also mobile crisis response, crisis stabilization facilities, and community-based alternatives to 911 emergency response dispatch. The third strategic direction of surveillance, quality improvement, and research. Good quality data enables the evaluation of suicide prevention efforts and is really important for applying suicide research advances to improve prevention practices and ultimately to reduce the incidence of suicide. The strategic direction focuses on enhancing accessible and timely data on suicide thoughts, attempts, deaths, as well as data related to risk and protective factors, and the need to really promote rigorous research in the field. The fourth and final strategic direction of health equity requires active collaboration to assess and meet the needs of all individuals and all communities to respond to the growing disparities among populations impacted. Next slide. One of the most exciting pieces of this 2024 National Strategy release is the federal action plan that accompanies it. So for the first time, a National Strategy for Suicide Prevention includes a 3-year federal action plan that's designed to improve accountability for suicide prevention efforts and maximize the federal infrastructure. And this reflects levels of commitment across the federal government to address suicide that we haven't seen before. So federal agencies have committed to specific short-term actions related to the goals and objectives included in the strategy, and these they'll carry out over the next 3 years. Next slide. So if you are interested in reading the full national strategy and the federal action plan that accompanies it, both of these are available at hhs.gov/NSSP, and there's additional resources and materials that we continue to add to help spread the word and engage the full country in this national strategy. And I will turn it back to you, Ben.
Thank you, Sarah. I think it goes without saying that those of us in the field that have been paying attention to the space for a while, the launch of the Federal Suicide Prevention Strategy and 3-year action plan was a big deal. And so congratulations on all the hard work that I know went into that. To have such a comprehensive document that's out there that can help guide us is well overdue. And what you just said there at the end there, I don't want to skip over a bit, holding agencies accountable and allowing the public an inside look at what needs to be done is also just so unbelievably valuable for us. So thank you for your leadership there.
Absolutely.
Cindy, really excited to have you kind of close this out before we do our Q&A.
Sorry, had trouble getting off mute. Hi, everyone. I'm Cindy Herrick with the Policy Center for Maternal Mental Health. And today I am thrilled to be talking about maternal suicide and opportunities for policy and systems change. Next slide, please. So I'm going to go a little quick because I know we want to leave some time for questions, but a little bit about the Policy Center for Maternal Mental Health. Our mission is to close gaps in maternal mental health care through systems and policy change. We've been a catalyst for change in the field of maternal mental health by engaging partners, providers, payers, and policymakers. And of course, we always center mothers at all of our work. Next slide, please. Here's an overview of our current focus areas. So insurance coverage, access, and screening. And this is important because I'm going to talk a little bit more about this relation to barriers and recommendations for patients, providers, and policymakers when addressing maternal suicide. Next slide, please. So several years ago, the team at the Policy Center identified maternal suicide as one of the gaps in maternal mental health care. And we subsequently released an issue brief identifying these gaps and opportunities for improvement in this space. And since then, we've updated this issue brief annually, and we are just releasing our updated version this week. And we'll be, I think, dropping a link to our reports here in the chat. So I'm just going to quickly go over some of the updates that we made in this particular brief. In this refresh, we noted that the Federal Maternal Mental Health Task Force, which was formed after the passage of the Triumph for New Moms Act, which was championed by the Policy Center, noted in their first report, which was released of May this year, that maternal mortality is a priority issue in the US, and noted also that suicide and mental health conditions are leading causes of maternal mortality. We also noted some MMRC funding updates, which Sarah Foster from CDC had previously sort of gone over. Notably, we've increased from 44 to 46 states for MMRC funding and from 2 to 6 territories. And as previously, as Jill had mentioned, American Indians and Alaska Natives have higher rates of suicide than the other populations. So we also included the Suicide Prevention Resource Center's annual Tribal Suicide Prevention Needs Assessment in there. So to highlight that American Indians and Alaska Natives also have much higher rates of pregnancy-associated drug-related deaths and suicide when compared to all other racial and ethnic groups. And then we also had a few things in there about new research, and I'm not going to go into there since we're limited on time. And we also updated some of the treatment facilities. So there are still 3 inpatient perinatal facilities, but there have been increases in intensive outpatient and other facilities. So that's in the brief. Next slide, please. So first, we're going to talk about some patient barriers. We have stigma and fear is a big factor for patient barriers, because not only are you addressing the stigma of maternal mental health, we're also addressing the stigma of being a bad mother, and also talking about suicide, as been previously mentioned. There's also being the fear of being held inpatient, and of course, child protection services and having kids taken away if you disclose thoughts of suicide. Accessibility of care. There's a shortage of mental health providers and maternal mental health providers, which include a lot of different types of providers that include therapists and reproductive psychiatrists. There's inconsistent coverage of groundbreaking postpartum depression specific drugs, which can elevate risk for maternal suicide. And as previously mentioned, there's only 3 perinatal inpatient facilities in the US and 31 outpatient facilities. Next slide, please. And here are some of the provider and system barriers. Again, they revolve around training, board certification, lack of adequate insurance reimbursement, and access to care, which was similar to what was referenced in the patient slide. Next, please. We know that screening alone is not enough. And here are the current screening recommendations that we have from professional associations. Next slide, please. And we also note that there are screening recommendations from federal bodies such as the USPSTF. Next slide, please. So the recommendations for clinical recommendations is that the Alliance for Innovation in Maternal Health, also known as AIM, is a national cross-sector designed to support best practices to make birth safer. It's funded by HRSA, the Health Resource and Services Administration of HHS, and it's also led by ACOG, American College of Obstetricians and Gynecologists. And they create safety bundles, which are a structured way of improving the process of care and patient outcomes. They did issue a AIM bundle on perinatal mental health, and in there, they have recommendations of how to improve that, as well as addressing suicide risk in women during the perinatal period. And a big part of that is to take mental health history at intake. You know, as we know that as Dr. Wisner had mentioned, and there are some genetic factors that can lead to perinatal mental health issues, also bipolar. And so here are some of the recommendations from them. Next slide, please. Now we're going to move to policy recommendations. We recommend that CMS should require states to report HEDIS perinatal depression screening measures, and also to require measures to assess for suicide screening and safety plan development in obstetric settings and also in primary care. Next slide, please. And here are some recommendations for Congress. And a lot of that has to do with the Perinatal Quality Committee's PQC to implement the Zero Suicide Framework, which is noted in the strategic suicide plans that Sarah Brummett had previously mentioned, and also to implement the AIM guidelines. And then here are some of the other ones that I'll just, I won't read all of them, but next slide, please. So if you want more information about our new issue brief or facts about maternal suicide, please go to our webpage. You can go to our maternal suicide resource page or our reports page. Thank you so much.
Thank you so much, Cindy. This has been just like an amazing amount of information that's come at us. And I think having these resources like you just described and the hard work that you spent building those out. It's just so, again, valuable for our field. So really appreciate that.
Thank you.
I would like to open it up for all of us here for just a second. And we're doing a briefing here. We're talking to folks from all over the country, really looking at policymakers here today. So would love to just kind of start with, if each one of you could we could run the room and you could share maybe like the top policy recommendation or systems change that you would like to see that could best support maternal mental health, specifically around suicide prevention. What would that be? I know that's almost unfair. And even as I say it out loud, I'm thinking if I were asked this question, I'd say that's unfair, but I'm going to put you on the spot. Like what's like one thing that you would say, this is my top area that if I were sitting in the room with the person making the decision today, this is what I would tell them to do. And I'm just, for the ease of the audience and the ease of me, I'm just going to kind of run as we did today. So Jill, I'm going to start with you, and then we'll run the rest of our table here.
And we can have all the panelists come on camera, I think.
Okay, great. You asked the big questions.
I know.
And so many things, but I think if I had to start somewhere, I would say that we need to start asking and training clinicians to not just ask, but know what to do once you identify someone is struggling.
Oh, that's such a good one. I like that. Next, Catherine, Dr. Wisner.
Yeah, I like what Jill said, but what I would add to that is I am a big supporter of collaborative care programs. And you know what I mean by that is for maternity care services, and we did this in Chicago, we embedded 2 perinatal fellows in that maternity service. 10,000 women deliver there, and everybody is screened comfortably in that setting because nobody's afraid of, oh, well, you know, if I screen positive, what's going to happen? So there's immediate mental health support for screen positive women in large obstetrical settings. And there were a number of women who were highly suicidal who we were able to intervene with. So I would advocate for expansion of collaborative care models in maternity services.
Thank you. Sarah?
Yeah, I would echo that screening within a context of a continuity of care that can make sure a woman gets care kind of across a continuum, and then also includes care within her community, so she has social supports beyond that.
All right. Sarah Brummett.
I think I would second everyone's recommendations around areas to support healthcare and kind of serving this population. I would also add to the table some of the economic security efforts to provide that kind of support system for families. And so thinking about paid family leave and housing security and food security efforts, I think are really important to supporting families all of the time, but especially during perinatal and postpartum time periods as well.
Cindy?
I think I agree with everything. I think a big thing that we should also look into is the utilization of community health workers and peer specialists. As a mom with lived experience myself, similar to Jigna, I think it's so important to close that gap of reaching mothers where they are with someone who understands the journey that they're on. And I think that there is, you know, in addition to all the other gaps, but that warm understanding, I get you sort of feeling is so important in addressing, you know, especially an issue that is so stigmatized such as this.
Yeah, I love these. Jigna, I would love your thoughts.
I was going to pretty much say what Cindy said, that I think peer support, group support, you know, having a mom who's gone through it by your side, along with all the other tools and resources, is what's really going to, you know, bring moms to the other side.
Yeah, I love that. We had some amazing questions that came in through our Q&A, and I know we've answered some of them, but there's one here that I want to flag and just answer publicly, because I think we might have different answers to the question as I ask it. So just would love to have anyone's take on this. But the question is specifically around, Do you have any recommendations for the best data sources that provide current information related to the prevalence of maternal mental health complications or related factors, like screening or accessibility to care nationally at state levels? And where are these data being collected? I feel like we touched on bits and pieces of that throughout this presentation. So for the sake of the person asking the question, if maybe each of you that shared different data points and resources, if you could just kind of say, I would go here for that, that would be really helpful.
Well, I think that raises a pretty big question, because until recently, we actually haven't had much data. There is a new addition to the death certificate that asks about whether or not, if a woman dies, whether or not they were in the year before or after having had a child. So I think that hopefully we'll have some data available, but I don't think there's one place that you can go for everything.
And along those lines, I shared a good chunk of data from the maternal mortality review committees. The data I shared is at the national level, and I can drop the link in the chat. But there's also most states now have a maternal mortality review committee, and they put out a state-based report, so you can also get more specific data for your state if you look for that state report. And then in addition, I mentioned the Pregnancy Risk Assessment Monitoring Survey, which is we call PRAMS. It asks some questions around depression symptoms and depression screening, and in some cases also around anxiety and some other related perinatal mood disorders. So PRAMS has some basic questions, and then in some states has some more detailed questions as well. So it's a broader maternal health survey, but it asks some questions that are in the mental health space.
And the state report cards are interesting, sort of synthesis shortcut way to look at what's happening in states.
Really useful. Well, in our last 4 minutes here, I want to close with something that I think can be inspirational for those that are in attendance today. I want to ask each of you again, what's the thing that gives you the most hope in this space right now? Because we talked about a lot of really hard things today. We talked about a lot of things that are inspirational, aspirational, and hopeful. But if you just take a look at the field, what gives you the most hope? And let's end on that. And I'll let you go in any order that you deem most appropriate.
I'll start. To me, so I work with a population in DC that is incredibly underserved. And what gives me the most hope is the incredible resilience I see in these mothers who really want to be good moms and care for their infants in the face of violence in the community, all kinds of stressors. I just am amazed at the strength that these mothers have. So I would say patience.
Well, I would say that I started in this field in 1985, and you basically weren't allowed to say the word suicide because it was so misunderstood that people thought if you said it, you were going to make somebody suicidal. And so the field has come so far, and people in the country and the world, individuals who've experienced suicide and in this case, maternal mental health difficulties are speaking. So to me, that the research has led to increased knowledge, which has led to increasing the conversation. And that, I believe, is going to lead to reducing the negative attitudes, also known as stigma, so that people will and are seeking help, and that we're talking about it. That's the bottom line.
I'd also add the engagement of family members. We didn't talk much about postvention, about after suicides occur and the family and the community education that occurs. I think that's really important as well. And, as Jill was saying, as we're recognizing and being able to say suicide and recognize what it is as a terrible time, but one that could advance information and knowledge in communities.
I think I'm just going to hop in and say that I'm really hopeful that we're recognizing that somebody like a mother can have mental health disorders and be struggling with mental illness or have thoughts of suicide or suicidal behavior, but still get help for that and be a good mother and be a good parent. And that, it's not mutually exclusive. I think there's a stigma that having a mental illness or having these thoughts, XYZ is not great. But that's not true. And I think it's so brave, people like Jigna and other people, to really share their experiences, because there's so much power in that. And that gives me a lot of hope.
Well, I will close because we're at time. I will close just by saying that you all give me hope. It's wonderful to know that we have leaders in this moment like you all that are at the cutting edge of doing what's best for the moms and the families that are out there. So thank you for your time today. Thank you for joining us. I want to thank the Policy Center for Maternal Mental Health and the American Foundation for Suicide Prevention for co-hosting this. I want to thank our congressional sponsors that were able to share their words today. And thanks to each of you that were able to join. If there are any additional questions or comments, please follow up with any of our wonderful speakers. I know they would love to talk to you, but for now, we thank you all for your time and attention and look forward to working together.
Thank you, everyone.